One question? Okay. One question. Yep. Loud voice.
Yes.
So let me repeat the question. It's a comminuted radial head and a terrible triad, and you don't have a radial head replacement, right? No radial head replacement, and it's comminuted.
Well, first,
What would you do?
if you excise the radial head in the presence of incompetence of the medial collateral ligament, you've got a very, very unstable situation. I think trying to then stabilize that elbow, if you don't have a radial head, then I think what you need to do is after you've taken it out, see if you can get them some degree of stability. I would then probably supplement it, if I didn't have a radial head replacement, with an external fixator to give some stability to that lateral side, although my anxiety is regarding external fixators. Just be careful just excising that radial head. You'll then find it very difficult to stabilize that elbow any other way. Yes?
Should it be done immediately or should we wait till you can do a close reduction?
Yes, there's no reason why you couldn't do a closed reduction in the emergency department. If there's no neurovascular deficit, you can pop them onto the ward, obviously keep an eye on their neurovascular status, warn them that it may slip out. You don't have to jump in the middle of the night with those sort of injuries. And I would go back to theatre in a planned way, hopefully having either a radial head replacement or some way of stabilizing it if you don't have it.
I think we'll have to stop here because of the interest of time. Please continue in the coffee break. I mean, you know him, don't leave him alone. Just happen. Thank you very much, because it's a great topic and I think it's very interesting. So the next one is distal radius. Again, a very common fracture that most of us have dealt with. Who has not seen a distal radius fracture? No one, obviously. Very important topic. Shaleen will tell us about it. He's the local. He's actually our host. So if you need anything, any money, Shaleen is your guy.
Thank you, Hatim. Very good morning to everyone. I would like to thank Dr. Vikas Khanduja, Dr. Hatim Syed, and the organizing team for making me part of the third SICOT Education Day. It's indeed an honor to be amongst such eminent teachers and talented surgeons. Distal radius is a very vast topic, and I'll try to cover maximum possible in the allotted time. Okay, sorry. So these are a few key learning points that we'll be touching upon today. Distal radius fractures suffer from a few assumptions. That is one of the simplest fractures to treat. Comminuted or non-comminuted fractures all do well with the plaster cast. If not, the final outcome remains comparable. Patients comply with gross clinical deformity. Neglect DRUJ, it's not important. Arthritis is not a problem as it's not a weight-bearing joint. We will see as to how these things are not true. It's the most common fracture of the upper extremity as described before by Hatim. There's a bimodal age distribution. It peaks at about 5 to 14 years and later on 60 to 69 years. When you see the elderly patients, there's usually an extra-articular fracture with a metaphyseal comminution at times, and usually females. It's a low-velocity injury. When you look at the young patients, it's an intra-articular fracture with a high-velocity injury, and most commonly you see that in males. When you look at the anatomy, there are three articular facets, the one between the scaphoid and the radius, second between the lunate and the radius, and the third between the distal radial ulnar joint. The triangular fibrocartilage complex, or TFCC, is a primary stabilizer of the distal radial ulnar joint. It begins from the ulnar aspect of lunate fossa, and from the lunate fossa, and it goes and attaches at the base of the ulna and on the ulnar head and the base of the ulnar styloid. When you look at the applied anatomy, the cross-section of the distal radius shows multiple tendons, both on the flexor and extensor aspect. The extensor aspect, the dorsal aspect, you see a lot of tendons close to the bone. Similarly, you would see the tendons quite close to the volar rim, which tells us that the hardware, if stays prominent at these points, can cause tenosynovitis or even tendon rupture. When you look at the vault of the radius on the cross-section, you can see that the lunate fossa has a good density of bone because that's the primary load transmission area, and it's very important that one reconstitutes the lunate fossa anatomically. And if you see the third diagram, when you see the yellow line, that's the watershed line. That is where the implant should stay and should not go any further distal from that point. So biomechanical demands of the wrist are high and varied. It requires strength, stability, and precision. To meet them, distal radius is intricately designed, and these are the few radiological parameters that one has to monitor during the fracture, during the course of treatment, and on the follow-up. This allows the distal radius and the wrist to have a good range of motion. And a slight change in height and alignment, as seen by radial shortening or a dorsal tilt, can cause significant deterioration of the function and stability, as shown here in the ulnar impingement or ulnar carpal impingement. Articular incongruence can lead to secondary arthritis. Of the many classifications mentioned in the literature, the Swiss surgeons Rickley and Regazzoni mention a very good functional classification of the radius, where it divides into 3 columns. The radial column being the osseous buttress of carpus, and also gives an attachment for the intercapsular ligament. The intermediate column, which is the lunate fossa, which we just discussed before, is a very important area and is the area for primary load transmission. The ulnar column serves as the axis of forearm and wrist rotation and secondary load transmission. In this paper by Lafontaine in Injury 1989, he mentions the predictors of instability. Initial dorsal angulation more than 20 degrees, shortening more than 5 millimeters, dorsal combination of more than 50%, intra-articular fractures, associated ulnar fractures, and age older than 60 years. Any fracture with more than 3 of these criteria is likely to fail in casting. Following are the indications for surgery: a high energy injury, intra-articular combination or displacement more than 2 to 3 millimeters, open fractures or compartment syndrome, secondary loss of reduction, distal radioulnar joint incongruity, metaphyseal combination or bone loss. We look at the approach. Most commonly favored approach is the one between the radial artery and the flexor carpi radialis. One can also go between the flexor carpi radialis and the palmaris longus. However, the median nerve is in close proximity, and there are incidences of damaging or overzealous retraction of the median nerve causing complications later on. When you look at the dorsal aspect, one can go over the Lister's tubercle or slightly radial to it. Usually one goes between the second and the third and the fourth compartment, but depending on the fracture pattern, one can retract the tendons and put in a plate there. The treatment options range from plaster cast to plate fixation and many more, but that pretty much depends on case to case. When you look at the percutaneous spinning method, the dual K-wire, that is cross K-wire versus parallel K-wires, or a 2 K-wire versus a 3 K-wire construct, have comparable results. When you look at Kapanji technique of intrafocal pinning, they tend to have a higher incidence of complications in the literature. When you look at external fixation, we have a spanning or a non-spanning form of fixation. The spanning could be a dynamic or a static type. However, the non-spanning fixators were associated with higher range of complications, causing pin track infections, tendon ruptures, and so on. This is an example where a distal radius fracture was treated with the combination of the previous 2 described techniques with good results later on. Orbe and Fernandez popularized volar lock plates in 2002. This is improvement to the previous design of non-locking plates, which had high rate of failure in osteoporotic bones because they lost hold in these particular patients. So with this in place, life has become much better. And we now have variable angle lock plates, which prevent the complication of tenosynovitis, particularly flexor tenosynovitis caused by the previous designs. However, they are not the panacea for all types of fixations. Here you see a fracture, very distal volar rim fracture, as seen here. This was treated with a pin plate and a lock plate with good results. So one has to customize the treatment depending on the fracture geometry. Some doctors, Dr. David Rush, has presented this recently in Journal of Hand Surgery in 2012, where he uses distraction plating effectively in treatment of comminuted and osteoporotic distal radius fractures. Here's an example of the same. However, they require second surgery for removal of the implant, and the rehabilitation is also delayed because once you remove the implant, you have to get the range of motion set again. One can also use bone grafts and bone substitutes to fill up the metaphyseal void in case of a comminution. However, with the use of lock plate, the use of bone grafts is sort of limited. Wrist arthroscopy is something new which has helped us evaluating the intercarpal ligament injuries and the TFCC injuries and the articular reduction much better now. However, we need more data to support its evidence, to support its usefulness in treatment of distal radius. No fracture is immune to complications. Distal radius has a fair share of them, but there are certain complications that can be avoided. The implant-related complications like implant loosening can be avoided by using lock plates. Flexor tendon tenosynovitis due to hardware prominence as plate standoff shown here in the figure. Extensive tendon rupture, delayed rupture, could be avoided by using shorter screws and In this paper by Hogg et al. In 2013, which is probably the last month, they showed a dorsal horizon view where the wrist can be kept in supination and palmar flexion, and one can see which screw is on the longer aspect and can be replaced. This paper by Brandon Bushnell in JAWS 2007 mentions the indications and contraindications for osteotomy in case of a malunion, and he pretty much summarizes that in patients with functional disability without arthritis is a good candidate for osteotomy. Here's an example for the same with good results. RSD is a nasty complication and can be detected with a 3-phase bone scan. Oral difadipin and ganglion blocks have been quite helpful in treating these cases. To summarize, distal radius fractures have different configurations. They're not the same. They all require to be assessed properly. They have different sort of treatments. The outcomes could be varied. So careful evaluation of fracture personality, achieve and maintain acceptable criteria of reduction. Watch out for the distal radial joint and TFCC injuries, carpal bone fractures, intercarpal ligament injuries, other soft tissue injuries, or one might end up with abutment instability arthritis as shown here. And every day we come across with newer fixation tools and methods, but one has to remember that it's the archer and not the arrow, so one has to use the tools wisely. Thank you.
Thank you very much. Great talk. Do we have one question for Shaleen? It's clear. It's a great topic. Well done. So, the next talk is about scaphoid fractures. Difficult topic, especially for non-hand surgeons. So it will be interesting to hear Sudhir Warrior. He's one of the big hand gurus I understand in India, so no pressure.
Thank you, sir.
Okay.
Thank you, sir. We seem to be overspeeding on the information highway. Since morning, it's just mind-boggling information just whizzing past, and here's another 10 minutes of whizzing past. We don't need to harp upon the fact that the scaphoid gets its blood supply in a retrograde fashion. Neither do we need to get any further information on the fact that in imaging the scaphoid is probably the most difficult part when you're looking at x-rays that someone else has taken. Suffice it for me to say that when you look at the scaphoid in radial deviation, it flexes, and when you look at it in ulnar deviation, it extends and allows you a much better view of what you're looking at. So when you look at something like this and you can't make out whether this fracture is healed or not, you need to do a good view to find out whether the scaphoid is healing or not. The next thing is, where do these lines come up? Where is the proximal pole, where is the waist, and where is the distal pole, where does it start and where does it end? We generally tend to lump them up and say, this is a distal pole or this is a waist fracture. It's important to know that most classifications address the obliquity of the line of the fracture, because when the fracture is loaded like this, it tends to become unstable. And if there's any movement that's possible, you're enhancing the instability and causing a non-union to occur. From various papers, we realize that a lot of them are going to unite in any case. So our job is then to identify the truant 1/3 that are not going to unite or going to give us trouble later. When you see an acute fracture, should you conserve or operate them? Most papers would say if it's an undisplaced or a minimally displaced fracture, remember when they say minimally displaced, they use 1 millimeter as the displacement. Now it's so difficult to image this scaphoid that it becomes difficult to identify 1 millimeter in that. And so you've got to be very careful, get true size x-rays, and if not, you need to get CT scans done before you start embarking on this treatment. Most of these fractures are bound to heal well, and and this study shows that those fractures which were fixed, which were displaced or minimally undisplaced or minimally displaced waist fractures, there's no difference in the outcome with the conservative treatment, except that there was a greater risk of complications. But if it's a displaced fracture, then suddenly this changes completely, and you start now seeing that there's a 17 times higher chance of non-union when it's displaced. So you need to look at those which are not displaced And the thing that you find is that at times they displace during treatment and then they need to be treated a little more aggressively. And so Dias came up with this idea of an aggressive conservative treatment that you look at them repeatedly, and at about 5 or 6 weeks, if you find something like this happening, then you need to fix it with a percutaneous screw and stabilize it. The displaced fractures, the risk of non-union, as we've seen before, keeps on increasing. And this is an interesting paper that looked at it from a completely different angle and said that even in undisplaced fractures, if you're just going to fix all of them, it seems like an attractive alternative to cast immobilization in patients who understand the risks and benefits of the technique. So it's our duty to inform them about this if you're going to take up all these fractures and treat them. So to summarize that, if it's a displaced fracture, if it's a part of a greater arc injury, if it's an open fracture, if it's multiple fractures, or if it is a definitely proximal pole fracture, these need to be opened and fixed. You can assess the the severity of the displacement by looking at the lateral intrascaphoid angle, which again is a very difficult thing. And you realize that if this is less than 35 degrees, 83% of them are going to unite. But the moment it goes to 45 degrees, which means your angles, these are so difficult to draw. And if you're going to make a difference of 10 degrees, it just jumps down to 27%. So this is a very difficult parameter to follow. So at 6 to 12 weeks, if you're looking at a fracture like this and it seems to be uniting, you can convert that into a splint and they will generally tend to go on to good union. But if, on the other hand, you find it displacing, you find the formation of a cyst, or you find the humpback deformity, which is like newborn formation, which tends to make us feel that there is callus happening there. It's an intra-articular bone practically. There's articular cartilage all around it. There cannot be any callus. So what you're seeing is basically the overhang of an end-on view of a flexed scaphoid, which is overhanging the proximal pole. What do you do then? If it's a rigid fibrous non-union, you can just put in a percutaneous screw and fix it down. On the other hand, if it's lax and crepitant and it's painful, you need to put in grafts. What sort of grafts are going to use? If there's no collapse, you can use cancellous grafts from the distal radius, as done here. Or once you find the height to length ratio changing, then you need to get back the height of the scaphoid, and then you need to put in some structural graft, which could come from the iliac crest, or you could use a wedge-shaped graft, depending upon the kind of gap you're looking at. So what do? You approach the scaphoid between the flexor carpi radialis and the radial artery, curve your incision towards the tuberosity of the scaphoid, preserve the artery that crosses it if possible. Very often you end up burning it. It's not of great consequence, but try and preserve it as it has been in this. Put in your joysticks, spread apart the joysticks. You will find the wedge-shaped defect. What you see on the C-arm is like this. Before the spreading of the joysticks, pay attention to the intercarpal spaces. The moment you spread it open, you find that the wrist has been restored to its normal carpal height. Use a wedge graft, wedge it in, and that's on the C-arm, and then you fix it down with a screw. I did, in the earlier stages, use an additional K-wire, goes on to union, and give you good results. Should you use screws or K-wires then? When you're dealing with non-unions, K-wires are good enough. They give you up to 77% union, but screws give you much more than that. So I'd rather depend upon screws than on K-wires when I'm dealing with non-unions. What screw am I going to use? I'm going to use either the Whipple-Herbert screw, the cannulated one, or the AO headless screw, or the AccuTrack screw, depending upon the availability. But it's not the screw that matters, it's the placement of the screw that matters. If the screw is down the center, you're more or less going to get a good result. Would you pass it from the antegrade position or from the retrograde position would depend upon where the fracture is. For any fracture that's closer to the volar surface, that means the tuberosity or the waist, it's easier to aim that fracture from the volar side and go in retrograde. The position then generally would be about 45 degrees down and 45 degrees out with the wrist in complete dorsiflexion. Easy to place this wire and check under the C-arm. More difficult when you're dealing with the proximal pole. You've got to keep your wrist in complete palmar flexion and aim then for the base of the thumb, but then you can't pull the wrist back because your wire is going to bend. So you've got to push the wire right across if you want to see a good view on the C-arm. So you've got to get used to this. The time since the factors that affect a non-union and the outcomes when you treat them is the age of the patient, the time since surgery, failed previous surgery, and when you're operating them, if you find that the bone doesn't give you a good punctate bleeding, then the chances are that it's an avascular necrosis. You need to then think in terms of a vascularized graft. There are various options. The Zeidenberg graft or the 1-2 intercompartmental supraretinacular artery seems to be the workhorse, but it has been shown to have good results and then not that good results, and they've moved on. The same group has moved on to tell us that the medial femoral condyle grafts seem to be doing much better. It's a difficult decision to make, and once you make the decision, before you get to the scaphoid, this artery lies on the retinaculum. You've got to first identify it and then go down to see your scaphoid and then lift it up, and I like to take a stitch through it, create the gap, stitch the graft down because it's difficult to hold it down otherwise, and then fix it down either with a screw or, as in another case in this patient, with K-wires, and get it to unite and vascularize again. It's not always that it's going to heal. This is one of my patients who did not heal at all, and of late we've started raising the medial femoral condyle grafts. It's a little more technically difficult and demanding, requires the presence of the microvascular repairs, and you need to fix them. This patient is under treatment. I do hope he unites. There seems to be another source. We know the watershed line. Distal to that, there seems to be another source for a vascularized graft, which is being worked on now, and I think that's probably something that we need to look at. If you do not treat them well, they will progress to advanced collapse like this and start giving you pain in the wrist. This has taken 12 to 14 years to occur. But if it's a proximal pole fracture, this may occur in 2 years. And then your options are very, very difficult. And you're looking in terms of either doing limited fusions or complete wrist fusions to try and salvage the situation. So you need to identify them, image them properly, fix the displaced ones. When they collapse, get in the grafts, and if it's not vascular, put in a vascularized graft. Thank you very much for your attention.
Thank you very much, Dr. Sudhir. Do we have any questions? One question in the back.
I know it's difficult to get an MRI done in the UK, and it's much, much easier to get it done here, and it's much cheaper to get it done here than to get it anywhere else probably in the world. But I don't think you need that for all the doubts that you have in your mind. If you get a good X-ray with the ulnar deviation, and additionally, I didn't have time to put that in, but additionally tilting the beam 30 degrees, you'll see the scaphoid in its full glory standing up completely. The only fallacy of that view being that if it's an oblique plane fracture, then it's going to be overlapped and you're going to be a little, it's going to be difficult to find out. Then you take the mid-prone oblique view, and you should be able to see those fractures which will get overlapped in the previous view. Between these two views, I think it takes away the need for routinely imaging them with MRIs.
Thank you. I think, again, for the short interest of time, please continue the questions in the coffee break on a one-to-one basis. Thank you very much. The next talk by Basil Oster from the UK is going to give us an update on how to manage hand fractures. I mean, we've been dealing with them for a long time. A lot of people have been doing K-wires. We have conservative management. There are now the mini plates. Basil, tell us what's the latest with that.
Well, basically, I'm talking about the principles a little bit more, but basically how to manage them. Now our plastic friends in the UK are hijacking our management, and they want to take over the fracture of the hands because they said we are not good enough anymore. How they can cover that? How we will cover that? I'm going to go through quickly. All you know the bone anatomy, the anatomy of the carpal bone. We've been hearing 2 lectures so far. But this is a slide that I really want everyone to keep in mind, because I'm going to come back to it later, and this is gyrus limes. Now, we heard about the distal radius fracture. This was a great talk. And we need, because this is a common problem, the distal radius are common, the carpal fractures, including the scaphoid, are common, metacarpal fractures are common, phalangeal fractures are common. However, the uncommon problems, and the one that the A&E in the UK, they miss them, is the wrist dislocation and injection injuries. So distal radius fracture are Colles, Smith, Barton's. Distal radius fracture, angulation, displacement, and any articular extension. Now, it's very important, as I appreciate our colleague who said that it's very important to do reduction, maintenance of reduction until union, and rehabilitation. You choose plaster, wires, external fixator, dorsal plate, volar locking plate. But the most important, ultimate function results depends on the anatomical restoration of the fracture. Now, so what is the important radiological parameters? Radial length, volar tilt, radial inclination, DRUG congruity, and significant ulnar styloid fracture. So we've heard about the rules 1122, and this is something to keep in mind when we are reducing any distal radius fracture. So what happens if we will lose our radial length? So we will lose our incongruent DRUG and become very painful, and restriction of motion. We will have ulnar abutment and ulnar head subluxation. And what will happen if we have malalignment? Then we'll have, again, limitation of motion, changes in load distribution, and this is mechanical load, and it's very important, and then mid-carpal instability and increase of risk of osteoarthritis. So this is an X-rays, and you can see how badly all our lines are gone into, into different kind of directions. So really the functional results correlate with anatomy, and this is something I really to give a message to all our young doctors that they have to keep in mind. Now, it doesn't matter how you fix it the way you like it, but the most important, restore the anatomy. So how we will assess the head injuries in general when we are first in line? So we will go see vascular supply, nerve supply, including the digital nerve, the tendons, try to ask them to move even a little bit, and bone X-ray, and then skin cover. So, avascular finger, I'm sure somebody's seen it. Sensation, it's very important as well, because this is very important documentation, especially where we come from. In the UK, they can take you to the court for that. Now, we are although concentrate only on the bones. Is the fracture stable? Is there any rotation deformity? Is the fracture intra-articular? Now, this is a literature disagreements. So, what we are tolerating, if it's less than 5 to 10 degree in the first and second metacarpal, we are happy. If the third metacarpal, we are happy with 15 to 20 degree. And if it's fourth and fifth metacarpal, 20 to 30 degree. However, in the few slides later, we will see that this is not the correct things. But we will not tolerate any rotation of the digits, because if you have 5 degree of rotation, you are overlapping with 1.5 centimeter. Nobody likes that. If we have a 1 degree or to 5 degree finger trip, more rotations. So, shortening deformity, less than 40 millimeter, I'm happy. More than that, probably I need to think about fixing it again. 2 millimeter of MC, we have to remember that. That's 2 millimeter of MC shortening produce 7 degree of extension lag. And we can see that. And here you are. So, this algorithm I will skip because I will go to the, sorry. Now, something to take home with you. Very simple algorithm, and it will resolve all our problem. We have displaced fracture, and we are trying to attempt a close reduction. If we are satisfied with our reduction and it's stable, then keep it well alone. If it is satisfied reduction, but it's unstable, but then reducible, i.e. reduced it closely, then just please put a small wire or an external fixator, but this is, I think, over the top. However, if it's unstable and non-reducible or unsatisfactory reduction, then please open, reduce it, fix it properly the way you like it. It doesn't matter. Just the most important, restore the anatomy of the hand. Now, multiple metacarpal fracture, I always think about them like a box. If we have a box, we have 4 corners. If there's 2 corners gone, then it's become unstable. So always we're required to fix them. This is one of our beautiful patients. Now, metacarpal neck fractures. Again, controversy. Very common fracture. Usually it's transverse. 4th and 5th metacarpals are mostly involved because of boxing. Among young people as well. Now, 5th metacarpal, it's about 11 to 34% amongst hand fractures. Now, if we clench fist versus solid objects, i.e., as I said earlier, the boxer's fractures, then the CMC joint is mobile, 20 to 30 degree. Then the apex dorsal angulation we have to look for. So, this is the mechanism of injury, very common. Angry young people with their girlfriends hit the hole. Now, this is a very healthy cynicism. And this is, again, another healthy cynicism. Now, this is the commonest problems. So, how we are going to treat the next femur, well, the 5th metacarpal? I used, when I was a young junior doctor, I had a consultant who used to tell me, whatever you get the angulation and the degree, just add 5 degree and it will be acceptable. Means never fix them. Controversial acceptable angulation between 20 degree to 70 degree. The malunion, it's most likely is going to happen beyond the 45 degree angulation. And they usually, because of the hyperextension MCP joint, shortening metacarpal, then it will shorten the resting lens intrinsic muscles spanning MCPJ around and compromise potential exclusion and ability to initiate MCP flexion. So, when we are going to fix them? A, if the patients complain. B, if there is obviously less range of motion. C, if we lose the contour of the metacarpal hand, but this is only in female most likely. If there is a painful grip on the metacarpal hand in the palm, and if there's 30 degree maximum acceptable angulation. If I want to accept only 30 degree, but as I said, in my practice, I will accept 75, 100 probably. Neck fracture treatments, again, you know, the 4th and 5th CMC joints, 20 to 30 degree mobility. The 4th and 5th, 20 to 30 residual angulation. The 2nd and 3rd metacarpal, 10 to 15 residual angulation. So, most likely, as I said earlier, I will always try closed non-operative technique in most cases. So I always try to keep them well alone. If not successful, I will put a wire. If not successful, then I will open it up and, you know, I have no choice. So this is just the maneuvers. Here you are, just showing some few pictures. So now the intra-articular fracture is never tolerated. We need to fix it. It's not acceptable to leave a hand with intra-articular fracture. So we always like to anatomically reduce it and fix it. So open it up the way you like it. Herber screw, any fixation, plate, you name it, you can have it. Phalangeal fractures, majority minimally or undisplaced, most likely conservative treatment. Again, tolerated only less than 5 degree. Because if we will look at it, we will see the laceration, posture, deformity, the swelling, the color, and the sweatings. And we can see how much we can just deform by 5 degree. So again, please do fix it. Most of them, they are intra-articular. This is mallet, so I'm not going to go through that. So something is really, I've seen it very commonly missed by our emergency departments, perineal dislocations. So why they send them home? Because they don't know how to read those Galile's line. And they are very simple, 3 lines, just to make sure that there is a sitting between the bones, and if they don't match each other or they are overlapping, then there is something unusual happening in the carpal bones. So radiologically, there is the scapholunate angle is 30 to 60 degree, average of 47 degree. Radius lunate, the capitate, and the middle finger metacarpal are always in line. So the perilunate, volar lunate, are the incidence is 3% of all carpal injuries. Diagnosis is by PA X-rays. Lunate triangle, gyrus line, carpus foreshortening due to overlap. Lateral view, capitate dorsal to radius, spill teacup sign for lunate dislocation, and destruction views with muscle relaxation. So, few photograph of that. And you can see that there are, it's very interesting X-ray, how the dislocation of the carpal bones. And this has been sent home, and we received it in the fracture clinic. You fix it, again, if needs fixation, if there's scaphoid, you know, this is fixation. The last things I really want to just come quickly, we do all injection in the clinic, right? And we need to be careful because this is a case I've received in A&E. And this was only because of an injection into the carpal tunnel. And this is what received, and we kept our plastic surgeon quite busy. So in summary, please took history, always, doesn't matter what, doesn't matter how good we are as a surgeon. It's very important mechanism of injury. Do examine, do go back to look, feel, and move. Do the X-rays, define the bony injuries. Ask yourself, is that anatomically accepted or not? Assess stability and think about definitive treatment. And thank you very much.
Thank you very much, Basil. Do we have one question? Yes. How do you immobilize after metacarpal fixation?
The metacarpal are fixed internally, not by wire, i.e. by a small plate or by screw. I will let them go ahead straight away. Maximum probably 2 to 3 days in some wool and crepe, but then I want them to mobilize. I will never immobilize the fingers because if you immobilize the fingers, then you are asking for a lot of trouble.
So as early as possible. I think any more questions, we'll direct them to Basil in the coffee break. I think
Our friend plastic surgeon are the one
Basil.
who's taking over.
Sure. That's a long, long story, I'm sure. I'm sure it took a long time. Thank you very much for this interesting talk. I thank you for attending this session. I hope you enjoyed it. We will be moving on to the next one.
Okay, that was a quick rundown through all the upper limb fractures. I know it's a comprehensive review course, so we do expect you all have some baseline knowledge before you come to these courses, and these are 10-minute lectures to give you an update on what's happening. So that's the format and that's the focus. So we move on to lower limb fractures now, fractures around the lower limb, and it's a pleasure to introduce Professor Osama Farouk from SICOT University in Egypt, who will moderate this session. And the first talk is going to be by Hatem, and he's going to talk to us on tibial fractures and pilon fractures as well. Okay, so he's changed it the third time. That's fine. We will get his talk later. So pleasure to introduce Kaan Irgit from Turkey, who will talk to us about proximal femoral fractures. So you're back on schedule.
Okay.
Okay, thank you for the kind invitation and to this meeting and this fascinating country, actually. So we will talk about proximal femur fractures. I will try to cover femoral neck fractures and intertrochanteric fractures, and we will assess the different injury patterns, clinical examination, radiology, classification. We will compare treatment options and identify factors associated with good outcome and complications. So I will start with a typical scenario. When we see a patient, an old patient who comes to the ER who fell at home and can't walk or can't move the hip with an externally rotated limb like this, if the patient doesn't have a prior history of hip surgery, it is generally a proximal femur fracture. And now we have to define what kind of fracture it is, and this patient generally needs a surgery. And we have to deal with all these comorbidities. So both neck fractures and intertrochanteric fractures are increasing health problem. In 40, 30 years, the numbers will threefold, and we will spend billions of dollars. and age is a risk factor. Being a woman is a risk factor. They generally require surgery, and timing is so crucial for both fractures. It's better to do surgeries earlier for decreasing the mortality, and they all have one or more comorbidities, and whatever we do, mortality is a significant problem. And also, young people can have this fracture too, but they generally have the fracture because of a motor vehicle accident or fall from a height. We all know the anatomy, but as a reminder, intertrochanteric fractures are extracapsular fractures. Why is it important? Because when there's a fracture line in the intertrochanteric area, it's not disrupting the vessels that supply the head. So these fractures or these patients have less complications like non-union or avascular necrosis. On the other hand, when there's a fracture line on the neck, these fractures can disrupt the vascular supply to the head, and the greater the fracture displacement, the greater the risk of the retinacular vessel disruption. So these patients can have non-unions or avascular necrosis. Displaced femoral neck fractures generally present with an externally rotated and shorter limb, but on the other hand, a non-displaced fracture, with a non-displaced fracture, patient will have an acute pain. They may not be able to localize the pain, but they're generally unable to walk without significant pain. We make the diagnosis through x-rays, AP and lateral, cross-table lateral views. If we have any doubts for the fracture, even in less than 24 hours, MRI can help us to define the fracture. As a patient here, 44 years old, sergeant who fell in the bathroom, we were not sure if this was a fracture line or this was a fracture line, so we had an MRI, and it was an obvious diagnosis. So Garden classified these fractures according to the degree of displacement, which relates to the disruption of the vessels, and Powell classified these fractures based on fractures or orientation, and it relates to the biomechanical stability, which means if we have a fracture line which is vertical like this, there will be shear forces on the fracture, so these patients are more susceptible to non-unions. And the management is based on a few things here. If the patient is not able to walk prior to surgery, we expect worse outcomes for these patients. If the patient have neurological problems, for these patients, the surgery can be delayed, or we may want to use a hemiarthroplasty with a bigger head for decreasing the dislocation rates. If the patient has a lot of comorbidities, it again may delay the surgery. If the patient has a prior arthritis of the hip, we may want to use a total hip replacement for these patients. So the fracture type and degree of displacement is helping us to decide the surgical treatment. Initially, putting these patients in slight flexion and external rotation may decrease the pressure under the capsule, so this may be helpful for the patient, but skin traction is not helpful for decreasing the pain. The most important thing here is rapidly to optimize the medical condition of the patient and do the surgery as soon as possible. Not urgent, but as soon as possible. So conservative treatment is only used for high-risk patients for surgery or anesthesia or non-compliant patients because of the high complication and mortality rates. So surgical treatment is either reduction and fixation through open or percutaneous techniques or arthroplasty. Luckily, young patients don't have these fractures so often, but when they have it, it's a surgical urgency. We want to protect the blood vessels, and we want to spare the head, so we want to fix these fractures as anatomically as possible. It can be done either open techniques, or we may use close reduction, generally internal rotation and other maneuvers to reduce the fracture. For non-displaced fractures, 3 canalated screws or a sliding hip screw is the choice of implant. And if we will use 3 canalated screws, we have to insert them in an inverted V pattern, and we have to avoid the posterior spur of the neck to lessen the chance of disrupting the vessels. If there's a basicervical fracture, sliding hip screw should be inserted with a derotational screw to avoid the rotation of the neck. When there's a displaced femoral neck fracture, and if there's enough bone quality, and if it's minimally displaced, we can still fix the fracture, even in elderly. but this is not the case generally. So we generally have to do a total hip replacement or a hemiarthroplasty. If we choose to use hemiarthroplasty, the results of the unipolar and bipolar hemiarthroplasty is the same in the literature. But if we choose to use, again, hemiarthroplasty, cemented arthroplasty has better outcomes. For the displaced fractures, a hemiarthroplasty has less complications and reoperation rates and cost. So it is, for displaced fracture, it should be the choice. And total hip replacement has better functional outcomes, although they have more general complications than hemiarthroplasty for displaced fractures. So when we look at the complications, AVN and non-union are the major complications. For non-displaced fractures, this could be up to 10%, but for displaced fracture, it is high as like 20 or 30% for both AVN and non-union. When there's a non-union, we can still use a valgus osteotomy to enhance the healing, or we can do a total hip replacement. Also, in order to avoid a subtrochanteric fracture, we should be inserting our screws not lower than the level of the lesser trochanter. So as a conclusion, these are different injuries in young and elderly population. The timing is crucial for good results and decreasing the mortality, and good reduction is the key for success. Fixation has better results than arthroplasty in non-displaced fractures, and total hip arthroplasty has better results than hemiarthroplasty in elderly active patients. Intertrochanteric fractures is almost 50% of the proximal femur fractures.